Hello, my name is Alexandra Cervini and I'm a SAGE dietetic intern. This is my comprehensive case presentation, which will discuss enteral nutrition support in head and neck cancer. Here is an outline of my presentation. First, I will introduce the patient. Then I will go over the etiology and pathophysiology of head and neck cancer. Then we will go through the timeline of medical events and nutrition interventions. Then I will review the current evidence for nutrition practice. Then we'll go over the practice interventions versus the interventions that took place. Then we'll have a discussion, conclusion, and lastly, you'll see my references at the end of the presentation. CV is a 59-year-old female with a medical diagnosis of stage 4 squamous cell carcinoma of the left palatine tonsil. She has a past medical history of GERD, hypertension, acute kidney injury, and she has status post-PEG tube placement and port placement. For social history, the patient is widowed. Her husband died a few years ago from head and neck cancer. The patient is a former smoker, and she smoked around 10 cigarettes per day and does drink wine occasionally. The patient is 1.7 meters tall and 38 kilograms, which puts her at a BMI of 13.1, which indicates that she is underweight. Her ideal body weight is 61 kilograms, and the patient's usual body weight was around 52 kilograms. Over the past year, the patient has lost a total of 27% of her body weight. The patient is severely malnourished and cachectic. This patient has had a complicated nutritional hospital course involving multiple admissions, PEG tube feedings, and changes in tube feeding formulas and administration, which I will go over more thoroughly later in the presentation. CV was diagnosed with stage 4 squamous cell carcinoma of the left palatine tonsil. This diagnosis is classified as an oropharyngeal carcinoma, which is a type of head and neck cancer. Head and neck cancers impact the oral cavity, pharynx, larynx, paranasal sinuses, nasal cavity, and salivary glands. Normally, these types of cancers begin in the squamous cells that line the moist mucosal surfaces inside the head and neck. And approximately 38,000 people in the United States are diagnosed with a head or neck cancer annually. Alcohol and tobacco use are the two most significant risk factors for head and neck cancers, especially cancers of the oral cavity, oropharynx, hypopharynx, and larynx. And at least 75% of head and neck cancer are caused by tobacco and alcohol use. In addition, a number of cancers of the oropharynx have been linked to HPV, or genital human papillomavirus. HPV is a sexually transmitted infection which infects the genital areas of men and women. Each year in the United States, more than 2,370 new cases of HPV-associated oropharyngeal cancers are diagnosed in women, and nearly 9,356 are diagnosed in men. Other risk factors for head and neck cancer include consumption of preserved or salted foods, poor oral health, occupational exposure, and radiation exposure. The signs and symptoms of head and neck cancer include a lump or a sore that does not heal, a sore throat that does not go away, difficulty swallowing, or a change or hoarseness in the voice. In order to uncover the cause of the signs or symptoms for a problem in the head and neck area, a physician must assess a person's past medical history, perform a physical examination, and order diagnostic tests. If the diagnosis is cancer, a doctor will want to find out the stage of the disease. Staging helps the doctor find out whether a cancer has spread, and if so, to what parts of the body it has spread. Treatment for head and neck cancer depend on the site of the tumor, the stage of the cancer, age, and overall health. But oftentimes, treatment for head and neck cancer will include surgery, radiation therapy, chemotherapy, targeted therapy, or a combination of treatments. Prognosis in head and neck cancer depends on a variety of things: the stage of the cancer, the number and size of the lymph nodes with cancer, whether the patient has an HPV infection of the oropharynx, or whether the patient has had a history of smoking more than 10 packs a year. But it is estimated that 12,290 deaths will occur this year from head and neck cancer, which includes 8,900 men and 3,390 women. CV was first seen at the Cancer Treatment Center. At the time, the patient had not been seen by a physician in 5 years until she developed a sinus infection. The patient subsequently developed a sore throat and dysphagia, which was not resolved with over-the-counter medications. She was evaluated in the emergency room, and it was observed that the patient had a large left-sided neck mass in the left palatine tonsil region, which is right over here. She had a biopsy of the oropharyngeal lesion in June, which revealed invasive, poorly differentiated squamous cell carcinoma. After the initial assessment at the Cancer Treatment Center, CV had a dental evaluation and extraction of all her teeth. The patient was then evaluated by the speech therapist, and she had a PEG tube and port placed on June 17, 2015, and started daily radiation on June 28, 2015. Additionally, she received weekly concomitant chemotherapy during the course of her radiation. The patient was not a surgical candidate. Here's a brief look at the patient's video fluoroscopy. The patient was evaluated by the speech-language therapist and was found to be positive for severe dysphagia with aspiration risk and evidence of nasal regurgitation, which you can see as the fluid goes right up her nasal cavity. There are many possible side effects of head and neck cancer, including anorexia, dysgeusia, odonophagia, mucositis, weight loss, and decreased appetite. Many of these symptoms come from the actual treatment of head and neck cancer itself. As a result of the patient's radiation therapy, she developed dark patchy areas around her head and neck, which caused subsequent dysphagia. The patient had dysphagia prior to treatment due to the tumor location, but her dysphagia worsened secondary to the damage of soft tissues. She also suffered from cachexia, which represents a major cause of death in more than 20% of cancer patients. CV was admitted to the hospital for a PEG tube placement in June. An RD was first consulted on June 15th for the tube feeding recommendations prior to the PEG tube placement. At the time, the patient was having difficulty swallowing times 2 months, and she was only tolerating Ensure shakes, Jell-O, and ice cream. The patient had already lost a total of 16 pounds of her usual body weight, leaving her at 99 pounds. The patient's needs were calculated at 1,590 to 1,790 kcal per day, based on 35 kcal per kilogram of actual body weight, and 68 grams of protein based on 1.5 grams per kilogram of actual body weight. The RD's tube feeding recommendation was Gevity 1.5, 240 milliliter boluses 5 times per day, plus 866 milliliters of fluid flushes per day, which provided a total of 1,710 calories, 73 grams of protein, and 1,600 milliliters of fluid per day. A second nutrition consult was made from the radiation center due to an unintentional weight loss of 4% of body weight within 1 week. At this time, the patient was NPO with just tube feeding. Unfortunately, upon the previous discharge, the patient was not properly educated on the tube feeding regimen. The patient reported that she was consuming 480 milliliter boluses in the morning rather than the small 240 milliliter boluses 5 times per day, and consequently, the patient was only able to meet 2 to 3 cans of Gevity 1.5 per day due to the GI discomfort that it caused. The second registered dietitian re-estimated the patient's needs based on ideal body weight. The estimated needs were 2,135 to 2,440 kcal per day, based on 35 to 40 kcal per kilogram of ideal body weight, which is 61 kilograms, and 98 to 122 grams of protein per day, based on 1.6 to 2 grams per kilogram of ideal body weight, which was 61 kilograms. The registered dietitian also started the patient on a different tube feeding regimen, which the patient then tolerated. This tube feeding recommendation was 2-cal HN, 240 milliliter bolus 5 times per day, plus 1,500 milliliters in fluid flushes per day. This formula provided 2,400 calories, 100 grams of protein, and 840 milliliters of fluid per tube feeding, plus the 1,500 milliliters of fluid flushes, which equaled the total of 2,340 milliliters of fluid per day. Not only did the patient tolerate this tube feeding well, she also loved the taste. But the following week, the patient had a 2% body weight loss despite tolerating this tube feed at the goal rate. CV's most recent admission to the emergency room was on September 16, 2015. At the time of this visit, the patient was diagnosed with acute kidney injury and dehydration. The patient was also noted to have significantly diminished urine output. The patient was admitted inpatient where she was put on IV fluids in order to replenish fluids and electrolytes. However, a positive of this visit was that the patient did have a 1% weight gain from the last visit at the Cancer Treatment Center. And now onto the current research literature review. A literature review of 14 sources was completed to establish the most current and relevant recommendations for nutrition support in head and neck cancer patients. The research articles focused on nutritional recommendations for anti-cancer treatment and pros and cons of enteral nutrition in head and neck cancer patients. According to the textbook, Nutrition and Diagnosis Related Care, estimated requirements should be calculated using these standards. For calories, 30 kcal per kilogram of body weight to maintain, 35 to 45 kcal per kilogram of body weight to replete stores or if the patient is febrile, septic, or very active. For protein, 1 to 1.5 grams per kilogram of body weight to maintain, 1.5 to 2 grams per kilogram of body weight to replete to prevent muscle wasting, malnutrition, cachexia, and treatments. For fluid and micronutrients, use adequate fluid and hydration. Provide appropriate and adequate but not excessive micronutrient supplementation. For more current research, according to Aspen, nutrition support therapy is appropriate in patients receiving anti-cancer treatment who are malnourished and who are anticipated to be unable to ingest and or absorb adequate nutrients for a prolonged period of time, which Aspen defines as 7 to 14 days. Here's a chart for the indications of enteral feeding and the contraindications for enteral feeding from the textbook Nutrition and Diagnosis Related Care. The indications are inability to consume 50% of estimated needs orally for 1 week or longer, estimated or actual, a functioning GI tract with adequate capacity for nutrient absorption, and patient willingness to use tube feeding method. The contraindications are severe malabsorption that cannot be corrected with enteral nutrition, intestinal obstruction below feeding placement site, and conditions such as high output fistula or high aspiration risk. Percutaneous endoscopic gastrostomy, or PEG tubes, are the most common feeding technique for patients with head and neck cancer. Prophylactic PEG placement is often recommended with head and neck cancer patients who will be receiving radiation or chemotherapy treatments. This method is often suggested in order to avoid dehydration, prevent weight loss, and to help ensure the completion of therapies. Patients with prophylactic gastrostomy tubes have been shown to experience fewer hospital admissions for dehydration and malnutrition and maintain a higher quality of life during treatment compared to those receiving only oral intake. Table 1 shows the practice guidelines versus interventions that took place. When looking at the table and the comparison, you can see that the interventions that took place during the hospital stay were right in line with the practice guidelines for head and neck cancer patients. Now for the discussion. Were the evidence-based guidelines followed? Was sufficient clinical judgment used? Overall, the guidelines were followed for this patient. However, sufficient clinical judgment was not used upon initial assessment. The first dietitian based the patient's needs off her actual body weight when she was already very malnourished. Initially, the patient's needs should have been based off ideal body weight for repletion. I believe that it's very important to go based off the evidence-based guidelines, but it is also very important to use clinical judgment because, as you can see, every patient is different. So in conclusion, I just want to give you an update on how the patient's doing now. The patient completed radiation and chemotherapy on September 22nd, 2015, and then the patient was seen again by the dietitian on October 14, 2015 at the Cancer Treatment Center. And according to the MD's progress note, there is a marked reduction in the size of the ulcerated tumor in the tonsillar area. The patient is recovering gradually from radiation and chemotherapy. Unfortunately, the patient is still having significant difficulty swallowing. However, the patient is tolerating 100% of her tube feeding and is feeling better with improved energy. The patient is currently trying to increase PO intake, but only able to take small bites and sips at this time. And here are my references. Thank you so much for listening, and if you have any questions, feel free to reach out to me.